Principles of Neonatal Surgery. Dr. Abdul Rahman Al-Bassam, FRCS, Ed. Professor and Consultant, Head Section of Pediatric Surgery, Division of Pediatric Surgery, Department of Surgery, College of Medicine and King Khalid University Hospital, Riyadh. Principles of Neonatal Surgery. Types of newborns. Full term, greater than 38 weeks and weight greater than 2.5 kilograms. Preterm infant, less than 38 weeks with appropriate weight. SGA, greater than 38 weeks and weight less than 2.5 kilograms. VLBW, less than 32 weeks and less than 1.5 kilograms. There are physiologic differences between all these infants. Principles of Neonatal Surgery. High intestinal obstruction in neonate. Esophageal atresia with / without tracheoesophageal fistula, TOF. Infantile hypertrophy pyloric stenosis. Duodenal obstruction. Duodenal atresia. Complete. Weber stenosis. Annular pancreas. Lad band, malrotation. Proximal jejunal obstruction. Atresia, Web, stenosis, esophageal atresia and TOF. High intestinal obstruction in neonate. Esophageal atresia and TOF. Incidence, 1, 5,000 live births, 50% associated with anomalies. Types. Symptoms and signs. Excessive salivation. Respiratory distress. Inability to pass NG2. Choking and coughing on feeding. Voxeral syndrome. Esophageal atresia and TOF. High intestinal obstruction in neonate. Esophageal atresia and TOF. Diagnosis, clinical and CXR. Management, resuscitation. Comment type. Right thoracotomy. Division and repair of TOF. Primary anastomosis. Pure TOF. Division and repair. Isolated atresia. Greater than 3 vertebra. Staged surgery, gastrostomy and followed in 3 to 6 months by delayed repair. If fails then need esophageal replacement, stomach or colon. Infantile hypertrophy pyloric stenosis. High intestinal obstruction in neonate. Infantile hypertrophy pyloric stenosis. Incidence, 2 to 3 per 1,000 live births, more in whites. Age, peak 2 to 5 weeks. Sex, 4 to 1 male predominance. Symptoms and signs. Projectile vomiting, non-bilious. Failure to thrive. Visible peristalsis. Palpable mass. Infantile hypertrophy pyloric stenosis. High intestinal obstruction in neonate. Infantile hypertrophy pyloric stenosis. Diagnosis. Clinical and lab test. Ultrasonography. Contrast meal. Management. Correct dehydration in acid base with electrolytes. Biliomyotomy either open or laparoscopic. Duodenal obstruction divided into antenatal diagnosis. High intestinal obstruction in neonate. Duodenal obstruction divided into complete atresia. Partial, Web, stenosis, Lad band, annular pancreas. Antenatal diagnosis. Polyhydramnios. Dilated stomach and first part duodenum. Down syndrome 30%. Symptoms and signs. Vomiting, bilious 80%. High gastric aspiration, greater than 30 milliliters. Duodenal obstruction X-rays, management, double bubble shadow. High intestinal obstruction in neonate. Duodenal obstruction. X-rays. Double bubble shadow. Management. Excluded the volvulus. NGT. Stabilize before surgery. Duodenostomy, proximal jejunal obstruction. Atresia. Web. Stenosis. Treatment, and anastomosis. Case study. A 3-day-old baby boy who presented with HO of vomiting, which was formula milk and then green for the last 12 hours. He passed meconium last night. His mother told that his abdomen is full and feel firm. No perinatal problem. OE is active and mildly dehydrated. Abdomen is distended and non-tender with no mass. PR examination showed normal anus. Plain X-rays was a lot of dilated loops with multiple fluid levels. Clinical presentation. Low intestinal obstruction in neonate. Clinical presentation. Low intestinal obstruction in neonate differential diagnosis. Ileus/colon atresia. Meconium ileus. Hirschsprung's disease. Meconium plug syndrome. Left microcolon syndrome. Anorectal malformation. Medical causes. Sepsis, ileus, electrolytes imbalance. Common presentations: bilious vomiting. Low intestinal obstruction in neonate. Common presentations: bilious vomiting. Failure or delay to pass meconium. Abdominal distension. Multiple fluid levels in plain AXR. Ileal/colon atresia. Meconium ileus. Hirschsprung's disease. Due to congenital absence of ganglion cells in the distal bowel. Incidence: 1/4,500 to 5,000 live births. Sex: 4:1 male predominance. Age: 96% full term and 4% premature. Site: commonly, rectum/rectosigmoid. Less commonly, total colonic with or without small intestine. Hirschsprung's disease diagnosis. Neonatal. Delayed or failure to pass meconium with low intestinal obstruction. Late presentation: failure to thrive, poor feeding, diarrhea with abdominal distension and occasionally with enterocolitis. Examination: abdominal distension. PR: tight sphincter with gush of loose stool. Malnutrited child, enterocolitis. Hirschsprung's disease diagnosis cont. Radiographic studies. Plain AXR. Unprepared barium enema. Rectal biopsy. Suction. Full thickness. Hirschsprung's disease management. At birth. Pull-through operation. At 6 to 9 months of age. Primary pull-through procedure without colostomy, anorectal malformation, imperforate anus. Incidence: 1 to 5,000 live births. Common in boys than girls 55% to 65%. Low, below elevator sling. High, above elevator sling. Rectovestibular fistula, commonest in girls. Rectolateral fistula, commonest in boys. Management at birth. Posterior sagittal anorectoplasty, PSARP. Arm closure of colostomy.